of for cases and complicated cases, and I find a very interesting case, which is Parkinson case. And I would like to present the case, plus going through all the pathophysiology of Parkinson disease again, and see the updated things and updated approach, and see how we can better the way that we manage Parkinson versus the mainstream medicine, which they are focusing on just giving L-DOPA, which is metabolic part of managing chronic diseases, just giving them L-DOPA or anti-Parkinson's, anti-muscarinic. Um, I think we need to think more about how we can slow the progression of the disease and knowing exactly the pathophysiology that leads to the degeneration of the dopaminergic neurons and see how we can reverse that or slow that. We can just slow the process of degeneration. And because of that, I will go through, or we can go through a very nice animation, and I will cut those animations and just showing what we can do in and those pathophysiology that we're gonna learn from this animation, which is very interesting one, and it's very advanced. So you can see all the factors of the pathophysiology. It's not just one thing. It's not just that the dopaminergic neurons are dying and not producing enough of dopamine. But what caused the dopaminergic neurons death, and how we can slow that, how we can prevent that, and all the factors that leads to the dopaminergic neurons degenerations, and how we can hit them or target them with therapies. So let's go ahead and watch this nice animation, and then I'll try to cut it in a way so we can explain what we can do to target this pathology or this factor of pathology of the Parkinson disease. Um, can you hear the voice? I think I missed when I did the sharing.
Yes.
We can hear
Yes.
you.
You can hear the
We
voice
can
of
hear
the.
you, but we can't hear the video. No.
We can't hear the
Okay, yeah,
video.
okay. The reason why, pause the
Mm.
sharing.
You have the speaker thing muted. I could see it.
Not that well.
It said it had a muted sound. I could see the thing.
Let me do this. I need to maybe possibly. Oh, one participant. Let me see here. I need to take off the sharing thing. Is it? Can you see the screen?
Yep.
Okay. Stop the sharing. And then I need to do, when I do the screen, you see that you have to do share the sounds and optimize the video clip. If I don't do that, then yeah, then that's not coming out. Okay, now can you see the screen?
Yep. Now turn the sound on. See it
Okay.
there? There you go. There you go.
We turn the sound on, and let's go ahead and see it now. Can you see it?
Parkinson's is the second most common neurodegenerative disease after Alzheimer's. The most visible features of this disease are a slowness of movement, muscle rigidity, and tremors at rest. There are also many, often debilitating non-motor symptoms, some of which may present before the motor problems. Parkinson's affects many areas of the nervous system and different types of neurons. However, much focus has been placed on neurons in brain regions associated with the overt motor symptoms, notably a region of the midbrain called the substantia nigra pars compacta. This region forms part of a major pathway in the brain that's critical for facilitating movement. In Parkinson's, dopaminergic neurons in the substantia nigra gradually die, leading to the malfunction of this pathway and the characteristic motor problems. Drugs that replace or mimic dopamine are often used to treat these motor deficits, but they grow less effective over time.
So basically, those dopaminergic neurons, where their job is to is causing the brake. So if I want to move my arm, like flex the forearm, so I contract the biceps, I have to relax the triceps, right? If you don't relax the triceps, then you have this tone of the triceps will resist and stop the biceps from moving. And so we have to stop the triceps and cause complete relaxation of the tricep to allow this kind of movement and flexion of the arm. In Parkinson's disease, they cannot stop the triceps, the tone of triceps, and then you have this kind of reflexes active. So when you try to contract the biceps, the triceps will cause a reflex or initiate a reflex, and then you would have this kind of tremor, ongoing shaking, and then you have a problem with coordinating all your movement because you cannot move to the next one. And in some cases, like a case we're going to see, it's more into the articulation of the speech muscles or articular muscles. They're affected more than the body muscles. And you can see that he has stuttering when he speaks. He cannot move to the next word. And the reason because there is no breaks and that allow to move to the next movement. And also without the break, you will end up, those muscles are shaking because the antagonist is not being inhibited, and then you initiate kind of reflexes. And those reflexes will generate those reflexes will generate the tremor and those stuttering that you can hear from the patient with Parkinson's disease. So they're trying to talk, like if they start to speak anything, they say that, and they cannot move to the next, and also they cannot articulate properly because there is a problem with the breaks in the muscles and the problem with the coordination in general. And so that's the general, that's the problem with Parkinson's disease. I'm trying to simplify it.
Deep brain stimulation may also be used to treat symptoms. However, no current treatment slows the neurodegeneration.
That's one way, definitely.
A distinctive pathology in most cases of
or we give them, or we can stimulate those neurons possibly to release the dopamine. So that's one way of doing things. But there's more pathology factors of degeneration that we may able to halt or stop or target, and we're going to learn that from the coming slide.
Parkinson's is clumps of misfolded proteins within neurons. Louis.
So one of the pathology here is there's prions that they are being deposited, and those prions like waste that the neurons cannot get rid from, and they start accumulating to the point where they will kill the cell because they just like trash. Think about a house in your house, and you're not taking your trash out. So what will happen? The trash will accumulate in the house to the point, people will die inside the house if you don't take those waste out. So the same thing, there's a problem with recycling those prions protein and getting rid from it. So the problem is really in Parkinson's disease and even dementia or Alzheimer is the problem with recycling and neutralizing the free radicals and recycling those waste proteins and those prions and accumulation of those prions. Definitely one pathological factor that leads to the cell death.
Bodies are the most common type. A characteristic component of these is a misfolded protein called alpha-synuclein. These molecules.
So alpha-synuclein are actually an antioxidant. It's part of the superoxide dismutase, and those proteins, they get misfolded and they become alpha-synuclein, and they become prions, and they accumulate, and they end up with forming those Leo bodies. And again, and the neurons have a problem with recycling and cleaning up those misfolded proteins. Can we target that? Can we manage it? Yes. 2 drugs, methylene blue, actually 3, curcumin, methylene blue, and oxytocin. Those are three drugs proven it has anti-pyonogenic effect. Methylene blue, oxytocin, and curcumin.
Molecules can form small repeated units called oligomers, or longer fibrils. Mounting evidence indicates that these are toxic to neurons and play a key role in driving Parkinson's. Unwanted proteins are normally cleared by the cell's different types of protein-degrading machinery. Some evidence points to these systems being overwhelmed by misfolded alpha-synuclein and this might be a key factor in what kills the neurons. Parkinson's has also been linked to problems with mitochondria. Mitochondria provide cells with the energy to perform vital functions. They're highly dynamic and can fuse together or break up into smaller versions in response to a cell's energy demands. They can also be transported to areas of a cell that need them the most. However, in Parkinson's, these processes can be impaired, and mitochondria are unable to sustain proper neuronal function.
So the other mechanism of Parkinson is mitochondrial dysfunction, and they're getting faulty, and methylene blue, stem cells, exosomes, oxytocin, and all those mitochondrial drugs. Thiamine is very effective in restoring the mitochondrial function. That's why I like to add thiamine in our regimen in managing Parkinson's disease, especially high dose of thiamine. That's the new trend of managing Parkinson's disease. So anything that helps to rejuvenate the mitochondria, nitric oxide, NAD, glutathiones, CoQ10, all of those will help in managing Parkinson's disease. So it's not just one way of therapy. You really need to work on, it's like swimming against the flow of the abnormal genetics. And it's an extra cost to really go against the pathology, against the flow of the pathology. But that can be helpful if we are able to improve the mitochondrial function with CoQ10, methylene blue, oxytocin, name it. All those mitochondrial ingredients would definitely be a factor in managing Parkinson's disease.
As they become old or damaged, mitochondria are removed and replaced. Again, this recycling is thought to be disrupted in Parkinson's, leading to the accumulation of damaged or worn-out mitochondria. Another idea is that the cells called glia surrounding neurons may play a role in Parkinson's. As dopamine neurons...
So also we need to think about all the things that stimulate autophagy, and especially the recycling of the mitochondria, and anything that's helped to increase the recycling of the waste. And oxytocin is one of them. Fasting, all the things that we talked about would definitely help in managing Parkinson's disease.
Are lost, one particular type of glial cell, called microglia, is thought to take up the resulting cellular debris, triggering an immune response. Once activated, they release inflammatory cytokines, which activate neighboring...
So what will happen, of course, those prions, they can be picked up by the microglia, because those cells will secrete those prions outside, and microglia can take them. And what will happen if the microglia is taking those prions and all those free radical generators, and the byproducts of the dopamine itself. When we give L-DOPA, the L-DOPA will be degraded, and they give us quinons. Quinons are free radical generators. And quinons, they're patient with Parkinson's disease, they have a problem with recycling the quinons themselves. And they start accumulating, and they are free radical generators, and they start causing all this irritation, inflammation, and those quinons, and along with prions, and those are free radical generators. When they're being taken by microglia, it will irritate the microglia, and you have inflammation. So you have neuroinflammation. So if you see now that when we try to manage chronic diseases, we have the pillars of the managing chronic disease, the three pillars, right? Is to fix the redox, right? And also fix the metabolic and fix the immune system. So it's not just enough to give L-DOPA, because if you give L-DOPA and the Parkinson patients, they cannot really recycle the byproducts of L-DOPA, and the quinons will accumulate, which is byproducts of the L-DOPA, and they are free radical generators. They will cause more degeneration of the neurons. So L-DOPA, it's a sword with two edges. It's helping, yes, symptomatically, you're getting all this relief, you're getting the breaks, but those neurons, they have a hard time to recycle the waste. So when L-DOPA is metabolized into its byproducts, into its metabolites, which is quinins. Those quinins are free radical generators, and we have problem of recycling those free radical generators. Those antioxidants enzymes are expressed less in Parkinson patients versus the normal patients. They have some genetic defects in expressing enough of antioxidants and all this recycling system of the waste. So they will have accumulation of those quinins, and the quinins will cause more degeneration of the neurons. And so L-DOPA is good and bad, right? Because if you're giving L-DOPA and you're not taking care of recycling the waste of the L-DOPA, you may increase the process, or you speed the process of the degeneration of the dopaminergic neurons and of the whole progress of the disease. And then you need more of L-DOPA with time, right? Because you are killing more and more of those dopaminergic neurons from the waste of the L-DOPA. So how we can target that? Well, if L-DOPA or the quinins are free radicals, then give them antioxidants, give them IV glutathione, give them thiamine. Thiamine helps to express all those antioxidants enzymes. Thiamine helps to inhibit the P53, the apoptosis. So it has anti-apoptotic effect. It has antioxidant effect. It does have some anti-inflammatory effect, and so that would help. What are the things that helps to get rid from the quinins? IV glutathiones, right? That's the only way you can conjugate the quinins and neutralize them with glutathiones. And we're going to talk about the IV glutathiones and how it's very effective. And there's a lot of videos of Dr. David who used IV glutathiones. But again, if you give IV glutathiones, there's a problem there, because those glutathiones will metabolize and they will end up with glutamate, and even have glutamate toxicity. And glutamate is a free radical generator because they open up calcium channels, too much of calcium channels. So we need to antagonize the effect of glutamate. So what we will do, we give them NAC, N-acetylcysteine, right? That helps to recycle the glutamate. Plus resveratrol will help to block the calcium channels that's been opened by glutamate. So IV glutathione, too much of them, it's not good. You need to add NAC if you want to do IV glutathiones to recycle the toxic effect of the glutamate that's coming up from glutathione. We're going to learn that as well. So there is neuroinflammation that happen as well, because those neuroglia will take those prions, will take those quinons, and they get irritated and they get inflamed. And so we need to think about other inflammation. How and what kind of inflammation? It's mainly Th1, Th17. Th17, specifically Th17, is overactive. So you have a lot of neutrophils there. Okay, so what you need to do with immune modulation, try to shift away or push it away to Tregs and Th2, right? Okay, so what will be a good drug for that? Thymosin beta. What else helps? Low dose naltrexone, oxytocin, methylene blue. All of this would help to inhibit the Th17, shifting it maybe to Th2 and Treg. So anything that shifted to Th2, Treg, it's a good thing for Parkinson's disease. Inflammation, again, as I said, it's Th17, but also there's some active renin-angiotensin system as well. Low dose losartan will help as well in this process, because there is some abnormal renin-angiotensin as well in dihexa. It will be another thing. Intranasal dihexa. Dr. Mike Beamer has a very good intranasal dihexa, or even tablets. So we need to approach any chronic disease with the three pillars that we learn from chronic disease prevention management. Immune modulation. So we need to balance the immune system. We need to fix the metabolism. We need to restore the L-DOPA, yes. We need to see if there's any deficiency 6 hormones, work on that, leaky gut. All this metabolites needs to be restored. Optimize the health in general, metabolically. And then redox, it's very important to be buffered, right? Methylene blue, oxytocin, thiamine, all of that helps in increasing the expression of the antioxidant enzymes and neutralize the free radicals, IV glutathione, NAC, NAD, CoQ10, all those things that we talked about, improving the mitochondrial function. Inhibiting the P53, thiamine does that. So you need anti-apoptotic as well.
Microglia and another type of glial cell called astrocytes. Chemicals released by activated microglia and astrocytes have been shown to injure neurons. It remains unclear which mechanisms drive the disease process in Parkinson's. What is clear is that with time, more areas of the nervous system develop pathology. And one emerging idea is that this happens through the transmission of misfolded alpha-synuclein. While the multifactorial nature of Parkinson's disease progression might make it hard to fully understand, it does provide a number of potential therapeutic targets for slowing or even halting the neurodegeneration. For example, enhancing the clearance of abnormal proteins and blocking their transmission, improving the function of mitochondria, and targeting the neuroinflammation are all currently active areas of research.
And that's what we're doing for chronic disease prevention management, right? We are targeting the prions. We are trying to modulate the immune system, low dose naltrexone. We are trying to work on the mitochondrial, the redox, right, in order to manage Parkinson's. So the one way that the mainstream medicine, the neurologist, of giving L-DOPA, in fact, if you're giving L-DOPA without regard of the byproducts of L-DOPA, which is which is quinins, which will definitely they're a free radical generator, which will speed the process of degenerations. I can see that those mainstream medicine, they are speeding up the process of the Parkinson disease and maybe causing more damage. So it's very important that when we fix metabolically, we also need to think about how we can slow the degenerations and how we can make L-DOPA more effective. And so I recommend all the doctors, if you want to give L-DOPA, just give at least NAC, N-acetylcysteine, orally. At least this is the less thing you can do. But of course, as a chronic disease prevention, we recommend even more than that. We recommend giving all the methylene blue, vitamin D, everything that helps to enhance the antioxidants that buffer the redox, that modulate the immune system, that has anti-prionic effect or prionogenic effect, like methylene blue and curcumin. All of this, we work on it, and it gets costly, yes, for the patients. But it will slow the process of the degenerations versus doing one thing, and that one thing, it may help in short term, but it may speed the process of the degenerations where you need more L-DOPA and more L-DOPA, because you're killing those neurons by giving L-DOPA. And so it's very important to look at the waste. Just not enough to just feed the neurons without taking care of their waste, right? It's exactly like filling up the refrigerator and not taking care of the trash. You need to you fill up the refrigerator, but also you need to work on taking the trash from your house. Otherwise, you will cause more damage to the household.
Hey, Dr. Halasa, these prions, I know we've talked about them before as misfolded proteins and things of this nature, but how does that tie into the spike protein? Is it really kind of similar problem?
Well, spike proteins, that the vaccine and even the COVID itself, it's a prionogenic protein.
Right.
It can misfold as well. That's one of the problems that we're going to face in the future, is those spike protein are able to, or they become prions, and they deposit in the brain, and they will aggravate all those neurodegenerative diseases. So whether it's Parkinson or Alzheimer or many others. And that's why I think methylene blue is the answer, along with oxytocin, along with curcumin. And we need to actively start promoting this thing, because all of us, we got affected with this virus. All of us, most of us got vaccines, and those spike protein are pyogenic. So we need to stop it from now before they misfold and they cause all the problems. And taking methylene blue 10 milligram a day, it definitely helped to improve the cognitive function. So it's a good thing, even for your work, for your activities. And there is no reported any side effects of 10 milligram daily of methylene blue. And possibly that may help to slow the process or prevent those spike protein from becoming prions and aggravate all this disease that we learned. Okay. So I think we have here a very nice video from Dr. David. I know Dr. David Parliament. I think I met him at A4M. Dr. Klatz know him very well as well. But what he did, he just did IV glutathiones. And the idea why those patients are improving with IV glutathione, instant improvement. We need to know the mechanism here. In order to manifest Parkinson's disease, you have to at least have 75% of the dopaminergic neuron dead. Not dead, but not working. Let's say not working, 75% not working. And then 25 is function, right? Maybe less. Then you start manifesting the Parkinson's, right? Okay. So let's say this patient in front of me is Parkinson, and he has a manifestation phase Parkinson. So we assume that 75% of his dopaminergic neurons are not working. And while we give IV glutathione, and suddenly he's improving, and he start having those breaks working, and the tremor is less, and stuttering is less, and his speech is better. And the reason, because let's say if we say 75% are not working, does not mean that their 75% are dead neurons. We can say maybe 75%, 50% of them, or 60 or 70% of those 75% are dead. But the rest, which is 25% or 50% of the 75%, are stunned from the inflammation. So they're not yet dead. They're stunned with inflammation. They are in process of getting dead if we don't stop it. So we can say from the 75%, let's give example just to make it easy. 50% are dead, so there is no way to wake them up. Dead neurons. But the other 50% are stunned with inflammation. Stunned with inflammation, we can wake them up if we neutralize those free radicals, if we give them those anti-inflammatory supplements and things that we are talking about, oxytocin, methylene blue, IV glutathione, NAC, 6-hormone, all those good stuff. We may able to wake them up and they start functioning. And when they start functioning, you can see the improvement, instant improvement. Like half hour from giving IV glutathione. I saw these things in front of my eyes. Of course, and I was helping doctors in Libya. And you can see the improvement. It should be recorded here. I record those a patient with Parkinson's disease. We give them IV glutathione, but not just IV glutathione. Maybe David gave them IV glutathione, but I gave them oxytocin, methylene blue, NAC, thiamine, everything, right? So I can get all this multi-therapeutic effect and targeting all this pathophysiology, not just the IV glutathione. And we can learn the effect of IV glutathione just by watching this video. But again, what I did is more than just IV glutathione. I give them everything: methylene blue, oxytocin, vitamin D, everything that helps to target the prions, that target the inflammation, that targets the quinons, those free radical generators that's causing the damage and inflammation. And see what would happen if you wake up those stunned neurons, dopaminergic neurons, and they start functioning. You can get an instant relief of the Parkinson's disease.
The first patient is a 72-year-old man diagnosed with Parkinson's disease in 1994. His medications included Tasmar, Sinemet, and Mirapex. Clearly, this gentleman is significantly compromised by his Parkinson's disease. Ambulation is particularly difficult for him, especially in attempting to turn 180 degrees. At times, his feet appear to be essentially glued to the floor, despite his best efforts to get them to move. His balance is significantly compromised as well, and oftentimes the top part of his body tends to move more quickly than the bottom part. This obviously has important implications, making him at increased risk for falling and hurting himself. The patient was given 600 milligrams of glutathione intravenously. 30 minutes later, he is noted to be walking with much more fluidity and much better balance. He turns 180 degrees with much less difficulty and does seem to rely upon his assistant much less so.
So the stunned neurons are being waken up.
Steps are in fact much longer than prior to the glutathione, and overall the patient is feeling dramatically improved. The next patient was diagnosed with Parkinson's disease 8 years before receiving glutathione. At the time of his initial evaluation, he was taking Sinemet. The patient appears to be ambulating fairly well, but one cardinal feature of Parkinson's disease is quite readily apparent, and that is the lack of associated arm movements of ambulation, his arms essentially appearing to be glued to his sides. The patient does turn 180 degrees without significant difficulty, but it's interesting to note that there's a remarkable loss of facial expression. 15 minutes after receiving glutathione, 600 milligrams intravenously, the patient is observed to ambulate with much better arm movement.
So he was using 600 milligram, but in his new recent ones, he's using actually 3,000, 3 gram of glutathione. We're going to see that in the video. I used the 3 gram instead of 600.
His rate of ambulation seems to have increased as well, and the patient does appear to be somewhat more animated.
Again, IV glutathione is good, but if you do it too much, what will happen? You will have the glutamate, and the glutamate has toxic effect, neurotoxic effect. And the way we can recycle that is by giving NAC and also resveratrol. Resveratrol will be a calcium channel blocker, so it will antagonize the glutamate effect. And then NAC will recycle the glutamate and turn it into a glutathione.
The next patient is a 55-year-old woman diagnosed with Parkinson's disease 9 years prior to the administration of glutathione. At the time of her evaluation, she was taking Sinemet and Simetrel.
So basically, you will see a lot of cases like that, and then let's go ahead
cardinal
with another
features
one.
of Parkinson's.
This is a good one. This is a recent one of Dr. David, and he gave 3 gram of IV glutathione. But if you see, this patient is more, well, he has body tremor and all that, shuffling and all that. But also you have problem with his articulation, with muscle of articulations, with his speech muscles. And he has the stuttering. And that's what we're going to see in my case in Libya. It's more of stuttering than his body, muscles of his body. Let's go ahead and see this. So he's on Aldoba.
Okay, say today is a sunny day.
Today is a sunny day.
Good, can you stop and turn around? You walk that way.
Don't come back here, so stop putting on it, go.
Turn around again. Just walk that way, okay? Now we can stop. Say to You okay?
Yeah.
Today is a sunny day.
Today is a sunny day.
Good job. Okay. All right.
So now he's giving how many?
Good. Walk on down there. Go. Big step.
3,000. 3 gram. See how much
Come on back. Turn around.
This is how you wake up.
Come on, for me.
It's the last
Turn around. Let's go. Go for it. Big step. Come on. Turn around. Come on back. Turn around.
I feel a lot better.
You look a lot better. That was about a half an hour ago we gave it to the time. Huh?
Yeah.
Back.
Boy, now my legs are so much better.
There you go. All right. Let's get close to the camera.
Okay.
All right. Let me have you stop. Now I want to hear you say today is a sunny day.
Today is a sunny day.
How
Yes.
much is moving is
It is.
All right. Go ahead. Let's. Are you still recording? Let's see how he looks. Go for it.
Come on back.
Of course, we are more than IV glutathione. We recommend giving oxytocin, methylene blue, and NAC, and acetylcysteine, vitamin D, thiamine, a list of things that helps to target all those pathological factors of Parkinson's disease. And I think we can get better results if we do all of that. Dihexa versus just giving IV glutathione. So let's go ahead and see what's happening in Libya. Now, this is the patient, and you can mostly, he has some shaking in his body and some shuffling, but it's not that significant. He's just started. He's only 45 years, and he has Parkinson's disease for 2 years. And so it's the beginning of Parkinson. But most of the problem he has is the articulation, the speech. He has very severe stuttering. And let's go ahead and hear him talking, trying to pronounce his name. His name is Ashur, but we is trying to pronounce Ashur Kawan. Say So it's just the reason because there's no breaks. Dopamine is not breaking the antagonist muscles, allowing the agonist to work smoothly. And then what will happen if you have a tone, still high tone in the antagonist? Then you have this reflexes, right? And the shaking, and that leads to all the stuttering that you can hear from this patient.
شو اسمك انت؟
So he's asking him, what's your name?
قديش ليك مريض يا عاشور؟
So he has 2 years being sick with Parkinson.
سنتين. هاي تمام. عندك سكر.
He's asking if he's diabetic. Okay. So let's go ahead and see what's happening when he received IV glutathione 3 gram, plus he received oxytocin intranasal, thiamine injection. I think he received vitamin D, B12, all the good stuff, intranasal and injection. And let's hear him.
شو اسمك؟ عاشور كعوان.
You can see
شو
he's
اسمك؟
smiling.
عاشور كعوان. عاشور كعوان. ايوه. وين انت تو؟ مستشفى. مستشفى شنو؟ ايه.
Okay, so it still have, it's still there, but it's not as before. This is kind of improvement. This is just the first treatment. And then after 1 week, and he's receiving intranasal oxytocin, intranasal thiamine, intranasal B12, and also he's receiving oral NAC. And let's see what will happen here. This is
شنو
after
اسمك
1
انت؟
week.
عاشور يوسف كعوان.
شنو اسمك؟
عاشور يوسف كعوان.
قديش عمرك يا عاشور؟
45.
And he's saying, my name is
قديش ليك تو سنة
Ashur
مريض؟
Yusuf Kawan. That's his name. And he's 45 years old. And he's been sick for 2 years.
سنة ونص. ها؟
نعم.
وين قاعد تو انت؟
مستشفى كبار.
مستشفى كبار.
So he's in Kabao
تو الأسبوع
Hospital.
اللي فات فيه تحس روحك
Name is
أحسن ولا مش
Ashur.
أحسن؟
أحسن.
And
أحسن.
he says he's feeling good.
أحسن.
Saturday.
الحمد لله.
And he's saying, thanks God.
تاخذ في علاجك.
And he's receiving his medication.
تاخذ في علاجك بانتظام.
And he's taking his medication regularly. That's what he's asking him, and he's answering. So we want to see his speech, fluence of his speech. And I think there's not much problem with his walking yet, but there's improvement with his turning, and I think it's almost like normal. We need to see the before, but we did not picture the before one. This is after 1 week of continue every day of intranasal oxytocin, methylene blue, thiamine, NAC, and oral NAC, I think that's what he's taking. So he's taking a mix of cocktail during the weekday. And so we did IV glutathione every week. That's his program, and also 100 milligram injection of thiamine every week. And then oxytocin, we're giving it intranasal, the same way we're taking it here in the spray. And he's also taking B12 intranasal. And he's doing good during the weekday. And then we are trying to do the IV injection weekly for him for 1 month, and then we'll see, and then maybe possibly every month the injections and the IVs, and the rest will be just intranasal. I think that will be enough for his case. Very important is taking NAC
مشيتك
every
هذه
day. So the protocol here is glutathione IV weekly, and then NAC every day, intranasal or oral. NAD intranasal would be good. Thiamine, we give 100 milligram weekly, and then he can take the spray intranasal of thiamine. Methionine blue orally will be good enough, or you can do it intranasal. Cod liver oil is very important. I like cod liver oil or vitamin D and A, very important, because if you give vitamin D orally without giving vitamin A, you cannot absorb vitamin D. In order to mature the gut epithelium, even the respiratory tract, to provide that resistance against pathogens, especially respiratory infection, vitamin D A, it's very important. It helps to mature the gut epithelium and respiratory epithelium. It helps to manage the leaky gut syndrome. And it helps to increase the ciliary function and the mucus production and the mucosa function and maturation of the respiratory tract as well. So cod liver oil has the balanced mix of vitamin A and D. And that's the reason most of the patients receiving vitamin D are not doing good, because their epithelium is not mature enough to absorb the vitamin D. And I like the natural thing. I know it tastes awful, but if you mix it with olive, uh, um, with
Lemon?
lemon, I think
You
it
mix
would
it
help.
with raw fish, it tastes pretty good.
Right. But it just my wife, she doesn't like it, and she got the nausea, vomiting with it. But it's the best thing. But if you can make it in a way, and Dr. Mike Beamer is very good and make the flavor and change it, it may become acceptable by the patient. Oxytocin intranasal, I think Dr. Mike Beamer has it. B12, very important, B12, and I think Dr. Joseph has experience with it. Take it in the morning because it can cause insomnia at night. It just gives you that energy. And then 6 hormones. You can give HCGC. I think Dr. Patel, the patient with Parkinson's disease, and she's is taking HCGC, which and that stopped the tremor. And HCG, how it works, maybe it works directly, but mostly it works through increasing the testosterone. Testosterone has an anti-inflammatory, antioxidant of the 6 hormones. And I left it open. Say, health optimization in general. Whatever you want to do, it helps to optimize the health. There's lots of things that can be fixed in the patient, and you need to screen it. It would definitely help. The more you optimize the health, the better the outcome of the patient with Parkinson's disease, and you will be slowing the whole process of degeneration. Of course, adding curcumin will be another thing, especially with the prions. We know the curcumin helps to stain those prions and help to recycle them. But I let the door open for you to be creative. NAD is a good thing as well. But let's talk about more about the pathophysiology. Again, giving L-DOPA by itself, it's not a good idea. The reason because those dopaminergic neurons, they have a problem with recycling the waste of the L-DOPA. It's like, filling up the refrigerator and not taking the trash out. What will happen to that house? So that's what we're doing as a neurologist. If you are a neurologist, and you're just prescribing L-DOPA, you're just filling up the refrigerator and you're feeding the neurons, yes, with the dopamine, but at the same time, you are not cleaning the waste of the dopamine, which is the quinons. They metabolize the quinons. And quinins are very powerful, very nasty free radical generators. And the way that we get rid from it is definitely glutathiones, helps to conjugate them, neutralize them. You add NAC and acetylcysteine would definitely stimulate the antioxidant enzyme expressions, which is the all those superoxide dismutase and glutathione reductase and all the good stuff that we know about antioxidant enzymes. But also it's part of the glutathione, right? Cysteine and then glutamate and glycine gives you the glutathione. So we really need to work on um, recycling the quinons, which is the waste of the or the byproducts of the metabolism of the L-DOPA. Why? Because the quinons also is part of causing the priogens, causing of the misfolding of the protein, because they will oxidize those proteins and enhance the process of the misfolding and the priogenesis. And so clearing up the quinins would help to decrease the prions deposits, right? Um, and anything that helps to increase the reuptake of the dopamine as well, um, enhance the vesicular monoaminergic transporters, clear them from the synapses, because once they are in the synapse, they will be degrade and they will develop into or they become quinons. Glutathiones are a very important way of getting neutralizing and conjugating with those quinons and those free radical generators, and that's how we get rid from it. And so, giving IV glutathione, giving NAC, giving anything that helps to increase the recycling of those waste, the recycling of those prions, it's and also anything that inhibit the p53, which is the apoptotic genes, right? You want to keep those neurons alive. Thiamine is a good thing to inhibit the p53, and see what's happening here from this waste of quinons, right? When dopamine is being oxidized, it become quinons here, and see what would happen. Those free radicals, those quinons, they can cause mitochondrial dysfunction. They can cause synuclein profibrilis, right? They can cause a problem with proteasomes dysfunction, which is very important to recycle those prions. They can inhibit the autophagy, right? And they can lead to oxidative stress. So it's very important to recycle them. And how you recycle them with an NADH or NADPH, right? And reduce them. That's one way, or by conjugating them with the glutathiones. So giving NAD, it's a good thing too. NAD NAD, right? Intranasal NAD may help to neutralize those quinons. See how the glutathiones helps to neutralize them, conjugate them, neutralize them, and get rid from them and preventing them from causing all this damage, right? Causing mitochondrial dysfunction, causing gliosis, right? Because they will be picked up by the glial cells and they can irritate them and can cause neuroinflammation. So the more you get rid of those quinons, which is the byproducts of the L-DOPA, the better the outcome, the less degeneration of the neuron, you slowing the process of degenerations. And so it just shows you a whole process of how those quinins are bad guys. Those are free radical generators that leads to the prions, that leads to the mitochondrial dysfunction, that leads to inhibition of the lysosomes, and that definitely inhibit the autophagy and getting rid from all this faulty mitochondria. And so how we can treat it, just give them, the thiamine, NAC, glutathione, methylamine, quercetrine, resveratrol, all the good things, the polyphenols that we're giving, and optimize the health of the patients in general, right? And getting rid from those bad free radical generators, so buffering that redox, that and getting rid from those like those free radical generators and modulate the immune system. Low dose naltrexone is one of them, thymosin beta, dihexa, uh, and see if there's any deficiency And the vitamins, try to work on it, vitamin B or vitamin A, vitamin D or sex hormones, metabolically, you need to look at all the deficiency and fix those. The more you optimize the health, the better the outcome, and you slow the process of the degeneration. Um, then one will think about what is the similarity here? Do we have any cases um, where we have um, um, free radical generation of prions that leads to damage of the organ, and we're giving NAC and acetylcysteine as a treatment? Yes. Remember the paracetamol poisoning? When we giving, if we give paracetamol more than 10 gram or more than 150 milligram per kg, what would happen? The paracetamol would turn into a free radical. It's a quinine, right? And it's a form of free radical, it's a quinine. And it's a quinine amine, I think it's called, and acetyl P quinine amine, which is the NAPQ1. And those free radicals that generate from the metabolism of paracetamol, the liver cannot handle it. The glutathione cannot, we have is not enough to neutralize them, and they will cause damage and necrosis and inflammation in the liver, right? And what we're giving to those patients as an antidote, we give them NAC, N-acetylcysteine, because N-acetylcysteine will help to increase the expression of the antioxidant enzymes and will help to give you more glutathiones because they will react with glutamate and glycine, give you glutathione. So, and that glutathione will neutralize the quinines. So we have already clinical experience and treatment for neutralizing the quinines. It's the same quinines that's coming up from L-DOPA. It's a free radical generator. L-DOPA metabolized into free radical generators, which are the quinines. And the way we get rid from it is, yes, NAC is one of it, glutathione directly, NAD, and anything that helps to increase the expression of those antioxidant enzymes. Thiamine helps to increase the expression of those antioxidant enzymes along with NAC. And this will help to improve the mitochondrial function as well. So now we know that this is not something coming out of the blue. We are already doing it in the mainstream medicine, but why it's not being translated into neurology and into mainstream management of Parkinson's disease, I don't know. Up to now, the neurologists, they have no clue, or they don't have any concentration, nor they are recommending or prescribing IV glutathione or NAC or anything that helps to slow the progression of Parkinson's disease. And the reason is possibly it's not good for the big pharma because it's not good for L-DOPA business. And why? Because if you leave it like this, they will require more of L-DOPA, and you can sell more L-DOPA. And if you start adding all other things, then the sale of the L-DOPA will drop, and you don't need more of L-DOPA, and it's not good for the big pharma. And that's the reason they are dictating what the protocols needs to be performed in the hospitals. That's part of it. That's my maybe conspiracy theory. But us as a free autonomous doctor, we think outside the box, and we strongly recommend, if you're giving L-DOPA, if you're filling up the refrigerator, also take out the trash. Give them NAC and glutathione and all this, and empower them with antioxidant, because they have errors in their recycling and antioxidants enzymes expression. It's just genetic, and you're going against the flow. And yes, it is costly, but it will definitely solve the process of the disease. Mainstream medicine, if you ask the neurologist, he will say, no, we cannot slow the process or the progress of the Parkinson's disease. That's their answer. And they don't even try or think of it, because they say we need to have clinical trials and showing and prove that what you're saying is true. And that clinical trial will take 30 years, and nobody's going to fund clinical trials of giving IV glutathione, because there is no interest and no money generation for big pharma. So who is going to spend that money in creating those clinical trials that will satisfy and justify or satisfy the mainstream medicine and the big pharma. Um, Again, this is just shows you acetaminophen. We are using NAC as an antidote when we have acetaminophen poisoning, and the reason and the mechanism that acetaminophen turns into quinins, right? And you don't have enough glutathione to neutralize it, so the quinin will cause damage to the liver. To prevent that, we're giving NAC as an antidote to neutralize those quinins, those free radical generator.
I have a question for you, Dr. Halasa.
Yes.
What about glutamate? You know, whenever, in other words, you're saying if we give a lot of NAC to these patients, they do well. And you know they have dopamine deficiency. So, in what I'm wondering, just thinking from a point of view of psychiatry or neurotransmitters, that would mean that you probably have a lot of extra glutamate. And I'm wondering if one of the reasons they get better on NAC is because you're using up glutamate that's in, you know, excessive glutamate.
Yeah, so that's what we said, that it's not in, you don't give just IV glutathiones because it will metabolize and give you and glutamate. And I think Dr. Sherrill is the one who point to the glutamate as a neurotoxic. And yes, NAC will help to recycle the glutamate. And
Yeah, so I wonder that might be part of the impact that that treatment's having. You know what I mean? Is
right. So that's the reason Dr. David is recommending IV glutathione. That's not enough. You really need to give daily and NAC.
Yeah,
that's what I did
because you're
with this
quenching
patient.
the glutamate that's overexpressed now.
Right. So that's mean I'm antidoting the glutamate. Plus, I will give resveratrol because resveratrol it will work as against the glutamate. It blocks the calcium channels. So I'll give resveratrol plus NAC, and I will give IV glutathione like weekly IV, and then the rest of the days I would just give oral NAC and resveratrol to antagonize any glutamate toxicity. That's true. But I'm just showing here that it's being practically done by the mainstream medicine in managing paracetamol poisoning using NAC. And L-DOPA is the same thing. It causes poisoning to the dopaminergic neurons. And the way that we can slow the process of the poisoning with their byproducts is giving them NAC and glutathione and all the things that we talk, because this would help to neutralize the free radicals. I wish the mainstream medicine would change their protocols and add NAC, at least NAC, minimum NAC, orally every day with L-DOPA, and it has to be written in the scripts, because if you're just giving L-DOPA, you may help the symptoms, but you're speeding the process of the degeneration. I will let Dr. Joseph if he's interested, to give us a lecture on thiamine and Parkinson's disease. And thiamine helps to increase the expression of antioxidants, enzymes, same like NAC, but also it blocks the p53, and there's many other mechanisms. It helps the release of dopamine as well. But I want Dr. Joseph, if it's possible for you to go through this article, I'll send it to you, and then present us the thiamine with Parkinson and showing all the mechanism of action here. I mean, you can see it's very clear. It has an anti-inflammatory, it increases antioxidants expression. It has anti-apoptotic by blocking the B53, and it does help to enhance the synthesis of the dopamine by stimulating the tyrosine hydroxylase. But I want somebody to give us a complete lecture for thiamine and Parkinson. I think Dr. Joseph is a candidate, or Dr. Isam, as an anesthesiologist, if he's interested. Anybody's interested in presenting next week, especially if we can have the next week of thiamine and Parkinson, showing all the mechanism of action, because it's a new era. Or a new thing that's in Parkinson about using thiamine. And then dihexa also in Parkinson, it's a good thing because we can see there's some imbalance in the renin-angiotensin system, and the antioxidant, needs to be empowered, antioxidant arm of renin-angiotensin system. And I think low dose losartan will be good, or dihexa. It's the part of the antioxidants of the renin-angiotensin system. So dihexa, low dose losartan, and thiamine, all those are new drugs that's being used to manage Parkinson. So I wish if there would be a day for dihexa maybe, and then a day for Parkinson. But I think I'm done for today. If you have any question, please ask.
Yeah, I was going to mention something about the thiamine, and actually some things coincidentally I've been researching, connecting the dots, having some flashes of insight. Well, first of all, with thiamine, my understanding is that there's a lot of deficiency and we don't know it, and we don't have a routine test for it. And so people can respond very powerfully to thiamine supplements. In fact, I did when I was trying to figure out early on with the fatigue I was having what would work best, or I was just trying everything out, or discovering, oh, I might be deficient. The other thing I realized is that they have supplements that are conjugated forms of thiamine. They change it a little bit. I don't know exactly how that it crosses the blood-brain barrier, because that's the other issue, is the supplements may not necessarily pass the blood-brain barrier, so it's not going to give you the same effect. But the conjugated version, I think it's called salbutamine. Maybe I'm completely wrong. I forget what the name is. And then I also tried doing the intranasal with go ahead. Sorry.
Oh, I was going to chime in that, yeah, it goes by the brand name of Arkelion, this solbuthethiamine. That's I've been using it a lot, and it does cross the blood-brain barrier much better. So using it in depression and a whole bunch of neurological disorders and post-viral syndrome fatigue. So not just COVID, but any viral syndrome. So I was wondering to try and look at that to see if there's any studies with Parkinson's. I haven't looked specifically for that, but that would be an interesting idea. Yeah, and
Yes.
the other form of thiamine actually is it allicin from garlic is actually it's actually a form of thiamine. So so garlic and some of the other beneficial effects of garlic are probably attributable to that.
Well,
Yeah,
I could definitely
allicin.
say.
Yes,
Yeah, I can definitely say
the name for it is thiosulfonate. Thiosulfonate.
And what was the first one you said?
Allicin, ALLICIN. That's the name of it, but I guess the other name for it is thiosulfonate, and it's just basically a sulfonated form of thiamine, which is interesting. And then the other thing too is you mentioned about thiamine. So there's a few products out now that are nitrated thiamine, which is really interesting. So if you want to get your nitric oxide levels up like really quickly and really effectively, that seems to be one of the best ways to go.
Interesting. Well, I can say that the supplement that I did try, which I think is similar to the one that you're talking about that crosses the blood-brain barrier, it did feel like I just drank a cup of coffee, and that went on for a few days until I guess probably my body normalized. I probably did have some deficiency and I didn't realize it. But I guess this would be an example of beriberi, which was a real thiamine deficiency. I believe that I think it happened in Japan, and I don't know when. It was quite some time ago. But the more I looked into thiamine deficiency, I realized that was a big cause of central nervous system issues, and that this was not uncommon, and probably having to do with our food supply and mineral deficiency could be the reason. But what I can say is after a while, the supplement, sort of wore off. And I think, again, I felt so much better because I must have had some deficiency, and then my levels normalized. But here's the other thing. I was talking to the formulator of an NMN product, okay, and trying to figure out this NAD thing, like, because they could measure it, and I hear a lot of talk about NMN because that's the precursor of NAD plus. So I was trying to get things sorted out in my mind as to, okay, why this, why that? Why not just do an IV drip of NAD plus? But then I was like, well, that's probably short term. It's like you get an immediate elevation, but that probably goes away. And then I find out that there's no evidence, or there's evidence suggesting that IV NAD plus doesn't even get into the cells. And so if this is the case, then I would think that the oral supplements are not getting into the cells. And when I asked this formulator, I mean, he's a PhD, all of this looks like most of his studies are in NAD. He said it may be, or why would I feel better or why do people in general feel better with NAD plus, especially the drips? And he said it's likely from signal transduction. So the next thing I started investigating is I'm looking at, okay, with all this fatigue, okay, and me having the epigenetics to be more likely to have post-COVID fatigue, is it an energy problem related directly to NAD plus? Because, if there's evidence that there's a shortage of NAD plus, which would cause a suboptimal mitochondrial function. We know that there is an increase in PARP production, which is which NAD plus is part of the formation. NAD plus is part of the molecular construct of PARP. When the DNA is trying to protect itself from the oxidative stress that occurs from overexpression or overstimulation of the angiotensin type 1 receptor, leading to NOx stimulation, leading to superoxide, leading to DNA damage from too much oxidative stress. PARP gets transcribed, and that utilizes or sucks the NAD plus, you could say, away from the mitochondria, such that there's less mitochondrial function. But the other thing I came across, and I had a flash of insight because a few years ago, there was this concept of NAD plus recycling. This idea that you could recycle NAD plus. And then I took a second look at that, and suddenly I realized that there's a common thread amongst chronic fatigue, cancer, and I just looked up Parkinson's. A lot of conditions have, and just age-related diseases, age by itself leads to an overexpression of an enzyme called nicotinamide methyltransferase. And what that does is it methylates part of the recycling of the NAD plus, or the way that NAD plus is formed, or the way that NMN is used to build NAD plus. That's the recycling process that happens. That process gets blocked by this. It's called NNMT. It's nicotinamide N-methyltransferase. And when this enzyme is blocked, when it's doing the blocking, the NMN is actually just wasting. It's getting wasted, so it's unable to convert to NAD plus, and it gets wasted. And so I'm sitting there thinking, well, if we're going to supplement with NMN, Well, that's not going to work either if it's being wasted, if there's overexpression of this enzyme. The other thing I realized is that NAD plus has a much bigger role than I imagined because it's required for the activation of certain sirtuin genes, which are responsible for, or the master regulators of metabolism and inflammation and reducing the amount of TNF alpha and interleukin 6, which is obviously being overexcreted or transcribed and triggering the immune system to polarize. And suddenly I'm seeing article after article after article after article about this idea of blocking the NNMT enzyme such that NAD levels will go up. NMN is able to form into NAD plus. The other thing is part of this, that cycle involves the formation of something called SAM, which is like a methyl donor of some sort, and something I'm working on trying to figure out. But my understanding is that it's involved with it's important in the autophagy process. And so I'm looking at this saying, okay, so you've got this blocking of the nicotinamide methyltransferase leading to increased NAD plus levels, leading to increased sirtuin genes, leading to increased mitochondrial function, leading to increased autophagy. And now they're talking about it in respects to certain cancers. And so I'm here wondering now if this enzyme is kind of like one of those things you see it's being studied, across the board. And you see that there's actually a peptide or a small molecule that actually can block that enzyme, and it's actually quietly on the market, used as a weight loss, as a fat burning supplement. Okay, so I'm thinking that we need to investigate that. In fact, I'd like to talk about that maybe in concert with the thiamine, because even the thiamine leads to increased NAD plus. Perhaps it has, maybe NAD plus may be at the center of these dysfunctions, and really it's this overexpression for whatever reason with age and with certain conditions, this upregulated nicotinamide and methyltransferase, which is preventing the production of NAD plus, almost like it's the precursor to cancer. It's slowing down the mitochondria just enough that it can't quite power the cell, and so that the cell is like in an idle state, and nothing we do is going to work unless we can figure out how to get the NAD plus levels up. And if the NAD plus supplements that we're giving are not actually getting into the cell, and the NMN is not enough since it's being spilled, then we need to work on the enzyme that is blocking the production. And perhaps that's the culprit.
That's true. Yeah, it's possible. And then you also have precursors to NAD, which is like tryptophan and niacinamide, and there's probably others. But you're right, all those things can go wrong. But I can tell you, NAD definitely has some effect, but I've taken NMN too. And I know who you're talking about, the PhD guy from the NMN company. He's very smart. I agree with you. And I had the same conversation with him about that. I said, well, why do I not want to take NAD? It just seems simpler. And the explanation he gave me is that NAD is just kind of like exogenous supplementation of something, but it doesn't really involve enhancing or utilization of the intracellular mechanism to make the NAD, like all, and by using NMN, you're kind of allowing the body to make the NAD itself. You know what I mean? So you're exercising the enzymes and you're stimulating the process. That was kind of his explanation. And the other one that you mentioned that he said that I heard from him as well was that that NAD doesn't have the same effect on the inside of the cell as NMN, because NMN isn't really, it's allowed into the cell and then it's made into NAD, so it utilizes the cellular machinery supposedly. So that was the explanation, and you kind of reiterated that too. So that's kind of what, but I'm still really not clear on which one you want to supplement and why. I don't know that I have an answer.
Okay, I'll clear it.
Yeah.
Because the issue with chronic fatigue syndrome, cancer, and what I'm finding, and I just looked, suddenly you start looking at these other diseases, you look up Parkinson's and NMNT, and you see it's the same issue. It's an overexpression of an enzyme that blocks the production of NAD plus within the cell intracellular.
So your argument is that
it blocks,
I get it. So you're saying no matter how much NMN you give somebody, if they lack that, they can't make NAD out of it anyway.
Exactly. The NMM just spills out of the manufacturing process. I'm sure not 100%, but not enough that the NMN would be enough by itself if NMN is the true answer, not in the context of an upregulated enzyme that blocks the production of NAD plus from NMN. Okay. And there's a supplement out there that actually it's a peptide or small molecule. I'm still trying to decipher that. It's not easy to find. I knew about this 3 years ago, that literally blocks that enzyme, and it's actually being tested for adjunctive treatment for cancer, because it's the same thing in cancer, that that enzyme that's blocking NAD plus production is overactive, and then almost like in an attempt to keep the mitochondria at an idle state, to really just use glycolysis as a form of ATP production, so it can't really override the dysfunction that's happening. And there's not enough NAD plus production. Sirtuin genes and those master regulators are not being expressed, which also play a role in metabolism and modulating the release of TNF alpha and interleukin 6. So you're not getting so much of that transcription, which is triggering the immune system, the microglia perhaps.
And you know what triggers all of that, I think, Dr. Joseph, is ATP, believe it or not. Is ATP itself, excess ATP. It would upregulate those enzymes to prevent further production of ATP.
Oh, that enzyme you're talking about, the NMT. Yeah. So it's a natural. That's a great point. So it's a natural self-regulating system, except for when dysfunction happens, and it seems to be happening in the context of chronic fatigue,
inflammation,
with cancer and other related conditions. It's being overexpressed, and then it's slowing down the process. And NAD plus seems to be the big player, that if we can override that and block that enzyme, then NAD plus production goes up, ATP production goes up, sirtuin genes get expressed. And in fact, one of the articles, and I could go through these, even talks about that's actually the reason for the lymphopenia in post-COVID, or in COVID and post-COVID patients, is the suppressed NAD plus, perhaps either in the immune cells, maybe that's leading to apoptosis of T cells, or perhaps or slowing down the production through the thymus gland of the the T and B cells, or maybe it's happening at the level of the bone marrow. I don't know, but I'm seeing a connection between those these phenomena, and which means this is what it means. No, essentially nothing is going to work unless we can override that system and get the NAD production to go up. And we could give a bunch of NMN, but it's spilling, it's being blocked. That's not the answer. And I think all the things that we're doing, obviously with Parkinson's, I think that would be another puzzle piece to investigate to see if we can get to another level. Because I mean, it's amazing, seeing the people that are walking and how they, just like that, they can switch. I just came to the realization just recently that NAD plus, as I realized it may not be getting into the cell, I had no clue that there may be another way around it that we just didn't realize.
I can tell you, I think NAD works better.
I'll tell you what, I have
personal
gold
opinion.
right here. I have Quicksilver Scientific's NAD Gold. Now, what they have in here is trimethylglycine, and TMG is a methyl donor that I always recommend you use when you're using these products. It'll make it work better, and the PARP issue isn't such a big deal.
What's it called? Sorry.
Quicksilver Scientific, they have trimethylglycine combined with their NMN. But here I also have NAD in injectable form. And I can tell you from my extensive use with these in patients is that the injectable form is the only clinically significant one I've found. The other one, it might work for longevity, but you don't see that immediate brain clarity in these people with long COVID, their fatigue. You'd see this fatigue just alleviate when you give them injections of NAD.
I agree with you.
Well, and let me jump in and clarify, because I understand what you're saying. In fact, the first IV NAD drip I took was like life-changing.
Yeah.
Okay. But my question, is it possible that the effect is coming from a cell signaling effect, signal transduction? It's actually hitting a receptor on the cell wall, which is triggering the release of antioxidant or activating antioxidant genes, like NFR2, like we saw with that. And that's where the thinking better and the clarity, that's lasts for about a day or two, or maybe up to a week. It's not actually from elevating intracellular NAD. It's a signal transduction process. That's what I'm coming to realize.
Interesting.
I don't know if I believe that dude or not. It's hard for me to know. I agree.
Well,
I see what you're saying.
But the reason why that's a good point, why I took that point and ran with it is because in my mind before that, I was like, look, why don't we just do IV NAD and just do it every week if you have to.
Right.
Well, I can do my own IVs, and I've done that. And being a bona fide post-COVID fatigue person, I can tell you it didn't work.
Yeah.
I get limited results.
The thing I found with this post-COVID fatigue is there's a lot of different reasons for it. You can have low thyroid, you can have low testosterone, you can have low NAD, you can have low B12. There's a lot of deficiencies out there, and I found it's therapeutic in those who I think their deficiency was NAD, and giving it back to them brought back their energy again.
But again, I'm not sure if we're miscommunicating, and I respect your opinion and especially the results you're saying. What I'm suggesting is that that's exogenous NAD plus deficiency. Okay, like maybe that's the distinction it is, and it's the exogenous NAD plus that is, and when I do NAD plus, I do feel a lot better. It's just that it's short-lived, but it may not necessarily be the prime directive if it is true that it's the signal transduction that's causing people to feel good. It's not actually elevating and replenishing the intracellular NAD plus stores, which seems to be the chronic problem that we can't overcome because of this overexpression of the enzyme that's blocking its production. That's what
I
I'm saying.
got you. I hear what you're saying. It makes sense.
Right. So if I'll show you the articles, if I present it, I'll show you exactly what I'm talking about so that we can make that fine
So how about
distinction.
this, Dr. Joseph? Why you don't
If that's
just
the
put it
case.
together in a very nice presentation so we can see all the details and we can learn something, formally, a lecture from.
I think we should talk about mitochondria in depth, and I've thought about that for a while. Like just as a subject matter, and I haven't run into anybody on the lecture circuit that really is talking extensively and deeply about mitochondrial function and the drivers of it and the things that we're talking about here. But I think it would behoove the group to do it. I mean, I may not be the guy to do it, or maybe Halasa, you should do it, or somebody. But if there's somebody in our group that, or anybody who knows a speaker that's really adept at this whole mitochondrial ballgame, they are out there. I've heard them before, but I don't have one I can put my finger on. But I think it's a really good subject to master because I think it will bear a lot of fruit.
Mm-hmm. Yeah, absolutely.
But your thiamine question, Dr. Joseph, I'll tell you this. One of the things that very first thing Dr. Halasa and Dr. Weber asked me to give a lecture on was riboflavin. And I looked at riboflavin, and it does about 6 million different things. So good luck with the thiamine.
I'll help you.
Thank you.
The more I dug, the more I found, and it just went in a circle.
Well, the funny thing is I've been trying to learn autophagy, and I'm like, wow. I mean, it's almost like you have to have a PhD in autophagy alone. I mean, it's so much more complex. And then when you see that viruses actually have a way of hijacking it, it makes me wonder, okay, now we got another piece of the puzzle to try to figure out. I was even thinking if even with Parkinson's that, if that was, a part of it, especially maybe even contributing to the prion issue, because there's again, I'd have to do a deep dive and present it and, get us all talking about it. But it was almost like there was certain viruses were causing the endoplasmic reticulum, which is sort of the source of autophagy, to get tangled up. And for that reason, we're able to hijack the autophagy system and replicate within the autophagy system without even fusing. You had those autophagosomes that were not even fusing with the lysosome to be degraded. So I mean, it's like, oh my goodness! Every time I think I have some things figured out, I realize there's a whole other deal with seems to be a simple system,
Guys,
Yeah.
guys, hi. Listen, I love what you guys are doing. I really do. I mean, I'm very impressed, and I attend a lot of many more of these types of Zoom conferences than I'd really like to. And the energy and the activity and the intelligence is so much higher with what you're doing than any of the government organization Zoom meetings or conference meetings that I attend. It is off the scale. And I just had to say that because it just strikes me, right in the face how useless so much of this academic medical conferences are. People are just reading off of a script or reading, a chapter out of a textbook, and there's no interaction, and there's no batteries included. And what you guys are doing is really state of the art. I congratulate you very much. And the issue of focusing on mitochondria and mitochondrial dysfunction and aging-related disease and cancer is really spot on. It's something that I've wanted to see happen for a long time, and I support that entirely. I just had to say that. So thank you very much.
Oh, thank you, Dr. Klatz, coming from you. That means a lot. Thank you, the father of anti-aging medicine. So thank you for the
very
kind
much,
words.
Dr. Klatz.
Yeah.
Well,
But,
I guess
but
that means we have to do this now.
Yeah. Well, we owe it to ourselves, and I appreciate the advocacy on a good subject, you know. But yeah, that's good. And another thing, and that'll tie in maybe to another discussion on Lyme disease. I kind of took a tangent with another academy on Lyme disease quite a bit there lately, and Lyme disease ties into all of this just in the same way that we're talking about. But yeah, I would we'll put that together. Dr. Halasa, are you there? I think I lost you.
I'm here, and I think Dr.
Let's get
Klatz
somebody going on mitochondria. Can you figure that out?
Well, I think Dr. Joseph right now, he seems like very clever and smart
absolutely.
in AD, and I like him to put together a lecture. I mean, thiamine with Parkinson will be a good lecture for him right now, because that will complete the whole picture. I let it open for others to investigate thiamine and Parkinson, and then we can open up the door for mitochondria and NAD. And Dr. Joseph will be a good candidate. You, Dr. Mike Beamer, Dr. Isam is very good as well if he was here.
What about Dr. Weber's guy, Matthias? Remember Matthias?
Well, if you know anybody, just we're looking for more speakers.
Yeah, that dude is brilliant, and he knows a lot about mitochondria. You know. Okay, well, yeah, let's do it. I mean, I'm happy to help. So, very good. Any other comments for Dr. Halasa on Parkinson's disease? That was very interesting.
I like hearing more about glutathione. Here's another vial of mine of glutathione. I give myself these injections to all my patients, and I find injection to be the most therapeutic form, intramuscular injection of glutathione. I feel it. It's very helpful for treating pain and high inflammatory states. Patients who are under high oxidative stress, diabetes, arthritic sort of conditions, you give them intramuscular glutathione, and they'll tell you that their pain improves, that their arthritis improves, that they feel better, more clear.
Yeah, just make sure you add NAC in their regimen, just to add more spices and flavors to what you're doing. And it doesn't cost too much, oral NAC on daily basis. And you saw how much it's being used for managing acetaminophen poisoning, and how it's clenching those bad free radicals, which is the quinins. But if you have any questions, I will.
Did you say you gave 3 grams of intravenous NAC?
Of glutathione.
Of glutathione.
Yeah, glutathione, we give 3 grams, but if you see that Dr.
How
David,
did you afford 3 grams?
He gave 600 milligram in the first videos, but then he bumped it up to 3 grams in the next one, and I went to the next one. I mean, I went to the protocol of 3 grams. And this patient, what we have in Libya, he took 3 grams of IV glutathione, was being done inside a 500 ml of IV drip for maybe 2 hours or 3 hours of dripping. But it's just amazingly, I mean, the instant effect there, but we boosted with everything else. And that's the difference between what we're doing and what Dr. David is doing. And we're hoping that all of you will start managing neurodegenerative diseases with almost similar protocols, and then come up with the feedback. I know Dr. Patel is very good, and Kevin is very good in putting protocols and treating patients. But we need to hear from them. The more we hear, the more validity of what we're doing. And it helps also to upgrade the protocols that we're doing, especially there were here Dr. Juliet, when she was increasing the methylene blue dose for patients with Parkinson up to maybe 100. I mean, she went up to 100 milligram, right? She went with the high dose. And so all those changes and modification of protocol, like Dr. David, he started with 600 milligram in IV glutathione in the beginning, and now it's 3 gram. So this changing in the dosage and protocols, it just gives us better learning and updating of what we're doing.
All right. Well, we also want to thank Dr. Bethel and Dr. Hepburn for coming tonight. We have our Bahamian contingent here tonight. So it's good to see both of you here, and we hope you guys will come back soon.
Thank you.
Yeah.
We try to come as often as possible.
Thank you.
If you don't, I'll just come see you, okay?
Sure.
You'd be more than welcome.
I need to do that. I need to come to your clinic. We should have well, maybe this summer.
I spent 5 days with Dr. Kevin. I mean, Bahamas is like a heaven, especially their beach. It's so beautiful. Yeah. It's not like it's better than Florida. It's better than Miami. I mean, their beach is crystal clear, and the weather and the whole environment. It's just a little bit expensive, and I don't like the custom and the airport. A little bit, they give me a hard time. Otherwise, I mean, it's just a heaven on the earth.
Beautiful.
We were planning, me and Dr. Klaas, to go to visit Dr. Kevin. I think that plan is still active. We tried before when we have COVID, and that's the reason Dr. Klaas, said no. And because he doesn't want to have that testing of COVID and all the complication. But I mean, Dr. Klaas, if you're interested to move forward and have 5 days with Dr. Kevin, I don't think Dr. Kevin would mind that, right?
No, not at all.
Well, it's certainly a possibility. I don't know if I have 5 days clear in my schedule, but certainly 2 or 3.
Well, that's good. Well, anything else we need to talk about, guys? If not, I don't want to keep everyone past their time.
Just one last comment for Hartman. He talked about the glutathione. I think it's a great idea. I can vouch for that, the injectable, because I have two people I know who do inject a small amount if in the area intramuscular, like with the BD syringes, the insulin syringes, in areas where there's pain and inflammation, just for temporary relief. But also it's great to have around, especially I had one of my, I would say more of a friend, her husband, I had given it to her. I had actually ordered it for her at the beginning of the pandemic when there was the true cytokine storms were happening. And when they both got COVID and we were kind of scrambling around to figure out what are we going to do? I mean, she had methylene blue and a couple other things on hand, but it was really stressful. She was giving the glutathione every time the temperature spiked up to 103, and they would actually go down to normal. And she did that for several days, and he barely got by. We got him to the hospital. My point is, and I believe I presented this case a few years ago, and I can present it again. My point is, and this was before the studies came out that glutathione and that there was a correlation between survival and oxidative stress. I think there was a small Russian study that actually showed this to be true. So yeah, just having the glutathione around, not just for aches and pains, but I mean, it could be a lifesaver if there's ever a cytokine storm. At least buffering it until you can figure out what to do next. So just wanted to comment on that's not the first time I've heard it being used.
That's great. Well, I'm giving a lecture tomorrow on the ancestral diet, and you'll get to learn why it's important because of NAD, essentially, to summarize tomorrow's lecture. So hope you all will attend that one.
Oh yeah, that's great. If you guys can join Dr. Bill, you'll hear Stefan speaking tomorrow on dietary subjects. So he's got a lot of good information on that. And I don't know if you guys know this, but Stefan is a professional athlete. So he has spent a lot of time in training in athletics and all the things that go with that. And so he has special experience with these things. So,
Mike, may I ask you a question?
Please, hi.
Is there anyone in the audience who has personal experience with electromedical devices and mixing that along with home hyperbaric for fatigue or for general overall health? I'm looking for someone who's using several of these devices because I would like to explore for the academy electromedicine on a more profound basis, but I need to find someone who has a greater depth of experience than myself.
Are you talking about something like the
100%.
Beamer? Because there was a guy on last week, an ophthalmologist that was very experienced in all that, believe it or not.
Yeah, that's who I heard, and that's who I was thinking of.
Yeah. It was kind of a tangential subject for him, but he seemed to really know a lot about it.
Right. There are people now who are combining PEMF with hyperbaric, and I'm very curious as to what the experience really is.
Yeah, Dr. Klatz, I've done about 3 weeks in a row of hyperbaric, and of course I haven't been able to combine these treatments, but I do a fair amount of red light on a regular basis, just trying to just figure out this chronic issue of mine. Like, I look normal, I act normal, but it's because of all the things that I'm doing. But when I'm not doing it, I can crash, and I know that I'm not better. It's a constant struggle. My point is with hyperbaric,
unfortunately, since COVID, or not, maybe it's not even COVID, maybe it's just the degradation of our environment and the pollution, or even the deliberate toxification of our environments. We all are, we're all HIV patients now, and I've gotten used to. I can't say I've gotten used to it, but I've come to that realization. I take 60 pills a day just to be good, not great, just good. And without those 60 pills a day, I'm among the walking dead.
Yeah.
I understand too. I really do understand what you're saying. I could say with my experience with hyperbaric is that I do feel better on it, but I think there's fine distinctions we have to make, because it reminds me of NAD plus. Every time there's a treatment that seems like it's the big answer, it's like I do it, but it's like it's not like I'm like, oh God, I feel so great, I'm so much better. It's like I think I'm better, but the fine distinction is this is where I'm at with hyperbaric, is that, well, number one, you could see it as a regenerative process. So if there's a regenerative element, say regeneration of the brain, because you're getting all that oxygen, you're pushing the oxygen with pressure, feeding those mitochondria, getting those mitochondria to speed up, almost like turbo boost, so that the cellular processes can override for at least a little while whatever is suppressing it. That may lead to some regeneration, but that takes time. And so I don't know exactly, how long it's going to take to have more ongoing results. The other thing is the common thread